Hello everyone. My name is Preston Wolf. So I work with Arthrex. So I love all this basic science because I'm truly a scientist at heart, but now I work on the industry side. So this is going to be a little bit different than some of the previous talks. It's going to be a little bit more of a clinical application, specifically of PRP. I'm going to talk about our newest PRP product we call ACP Max. So as I said, I work for Arthrex. So I'm going to go over a little bit of our ACP literature. So it's our previous PRP product. That's more of a plasma-based system and the science behind it. And then we're going to go into a little bit of the clinical trends. So I also work on the human side. So I want to give you guys a little bit of information on what's happening on the human side, where we're seeing PRP kind of go. I think the veterinary systems and equine and canine medicine does a good job of guiding the human side as well, based off the clinical trials. So it's good to let you guys know what people are seeing on the human side and ways you could direct some studies to give some better information to the human side. And then we're going to talk about the ACP Max, our newest system, and what we see with its output and where we see that system kind of going in our algorithm of several PRPs we offer. So we're going to start with the ACP literature and the science behind it. So there's a few studies about ACP out there, well, quite a few. I'm just going to talk about two real quick. So one specifically looked at ACP versus HA and corticosteroid in 10 dogs with elbow osteoarthritis. They did a Texas A&M questionnaire and did a blinded lameness score. And overall, at 6 months, they saw an improvement with both treatments. The ACP had a significant improvement for lameness and had a greater subjective improvement at 1 week and at 6 weeks as well. Overall, like I said, they both improve, but with PRP, you have potentially less of these side effects of chondrotoxicity that you see with the corticosteroids. So it seems like a very effective option up to 6 months. And specifically for CCL tears in dogs, there was a study done with 12 dogs that had partial ACL transections with meniscal release. Their only treatment was either ACP or saline, and they did 5 ACP treatments over 49 days. And just to give you an idea, if you're not familiar with ACP, it's a mild increase in platelets due to being a plasma-based system, so it's about a 2-fold increase in platelets, and it's a Luca-reduced system. They tested various outcomes here in this study, and overall we saw ACP had a very significant decrease in the loss of range of motion up to 6 months compared to saline. And we also saw that there was an improvement on the decrease in lameness that was seen compared to saline up to 18 weeks. But then once you got to 6 months, it started to level out again. So this ACP had a improvement in lameness for a short period of time, but it wasn't extremely long-lived. Now, when we look at what the tissue looked like following the ACP, we see the synovium at 6 months had a non-significant reduction in osteoarthritic progress, but there was a less severe synoviitis visually with the ACP compared to the saline. And we look at the CCL specifically, we saw that the saline had a disruption of the other portion of the CCL, the posterior lateral portion, while the ACP visually had some evidence of repair in 5 out of the 6 animals. While we saw this visually, there was no significant difference in the histological outcomes in the cartilage, meniscus, CCL, or synovium. So that leads us to conclude that ACP can minimize range of motion, ACP minimizes pain and decreases lameness, and decreases signs visually of synoviitis and CCL healing at 6 months, but histologically did not reduce scores, kind of letting us know that it's not causing a healing of the tissue, but reducing inflammation, reducing progress, and increasing clinical outcomes of lameness and range of motion. So what do we see on the human side? So PRP is not an approved study for joint injections on the human side. It's only approved, most of the products are only approved for mixing with bone graft to increase handling characteristics. But there is still a wealth of data on injections into various joints with PRP. We actually see 107 randomized clinical trials on various joints, and we see great success. So we see 39 out of 41 knee studies of OA showing PRP as effective over other treatments or no treatment at all, and 14 out of 15 on the shoulder study and 15 out of 16 on elbow studies. And I think this is pretty remarkable because PRP is not one specific formulation in these studies. There's a wide variety, but even with all of these wide varieties of formulations, we still see positive outcomes overall. So when we go towards the clinical trends on the human side, people are starting to talk about PRP more of how its mechanism of action is occurring and causing these better clinical outcomes. So there's two ways that people talk about it. It's either from the growth factors and various proteins that are contained within the platelets, or they talk about the soluble factors that are in the plasma. These can be anti-inflammatory, anti-degradative. There can be various different types here. So this has led people to do platelet dosing studies to see if the higher growth factor percentage, higher platelets can cause better clinical outcomes, longer term clinical outcomes. Specifically, one that a lot of people like to talk about recently is the study by Bansal et al., and it's a 10 billion platelet gluco-reduced PRP study. They did this on 75 patients and compared it to HA, and they followed it up to 12 months. Overall, they saw a significant improvement in WOMAC scores, but this started to diminish towards 9 months, and at 1 year, there wasn't a significant difference, specifically at 1 year. So that led people to start to think that 10 billion is an ideal number, but we know there's several studies out there that maybe increased platelets, it has a diminishing return, but it's not well studied pretty much in the clinical data. So it's interesting that there's another study that came out around the same time by Chu that did 4.1 billion platelets of leukoreduced PRP. There's 322 patients in the saline control or PRP, a very big study out to 5 years, which is pretty impressive. They had a really good follow-up as well. And interestingly enough, we saw just as good or better outcomes with this 4.1 billion compared to 10 billion. If you want to look study, I know that's not really feasible to compare between studies, but we still saw great outcomes actually to 24 months with this study, which is pretty interesting. But I think the big part here is really these were leuko-reduced studies. You're not having these high neutrophil contents that can cause more inflammation in the joint. So when we talk about platelet dosing, there is a promising study that's in clinical trial right now at Vanderbilt Medical Center, where they have 4 different doses of platelets versus saline and 26-week follow-up. And this is 40 to 80-year-olds, and it's double-blind. I think this study, if it comes to fruition and goes to the end with good follow-up, this will give us a better idea of what this platelet dosing might be ideal on the human side. So now we're getting into ACP max. So what is ACP max? Like I said, ACP is a plasma-based system with about a 2-fold increase in platelets. But the ACP max is a new double spin PRP. So a lot of people with these double spin PRPs, they'll do a slow spin first and then pellet everything else at the end. We decided to take if you might say, a different spin on this. And we did a fast spin first, removed almost all the platelet poor plasma, as you'll see here. Oh, wait a second, getting ahead of myself. So for Equine, it's 3,000 RPMs. For the time, depends on the volume. If it's 30 mils, it's 3 minutes, 60 mils, 6 minutes, 90 mils, it's 9 minutes. So you get this nice separation with this buffy coat layer. You remove your platelet poor plasma until you get 2 tick marks above the buffy coat, which is about 4 milliliters. You then remove the next 15 milliliters in our typical ACP syringe, and you spin this again. Again, this is a slow spin like our typical ACP system of 1,500 RPMs for 5 minutes. So with this slower spin, we have optimized it so you have your red blood cells and white blood cells in the bottom and your platelets and PRP in the top. So what do we see with platelet count here? In Canine at 60 mils, we get 4.9-fold increase. With Equine at 6.7 mils, at Equine at 90 mils, it's 6.7-fold increase. And a leading competitor in the equine market has about the same fold increase. If you see here with the Equine and Canine, this is our typical volume output, and this would be the total platelet output in your final product. And if you look at neutrophils, the ACP Max system does a really good job of removing almost all neutrophils, greatly reduced neutrophil content, which, like I said, in the clinical trials on the human side, this may be very important to reduce this inflammatory response that neutrophils would have by being injected in the joint. Again, we have almost no red blood cells in ours, and interestingly enough, when we look at the canine side, we start to see some products that are reducing red blood cells, but they're still a very pink color like this. So that when we looked into this a little further, it was actually interesting that there was a high heme concentration, so there was some lysis of the red blood cells. So why is all this important? Well, as you can see, erythrocytes, if they're present, they can feed into chondrocytes and chondrotoxicity through lysis and acting on chondrocytes. Also, the red blood cells can activate macrophages and have a feedback loop of high MMPs and inflammatory proteins. So what are we doing at Arthrex on the human side? Well, we've started a feasibility study on the clinical side to see if our new ACP Max system with this higher dosage of platelets can be used as a single injection for knee osteoarthritis for these patients, because there aren't any products out there that are accepted by the FDA for this use. So it's going to be 30 patients with ACP Max and 15 with Depot, and we're going to have a 12-month follow-up and 45 patients and going to be double-blinded. Now, I know some of you are thinking, well, what if I want some type of inflammatory reaction for a very short-lived, say if you're injecting into tendons or various other places? We also have another product called Angel that uses a plate centrifuge and a 3-laser technology to separate your blood components into various compartments, and you can separate this based on hematocrit percentage. So the higher hematocrit percentage, the farther it's going to dig into that buffy coat, and the higher concentration of white blood cells and start to get red blood cells in there. So this allows you to really customize your output, and this system also is able to concentrate bone marrow aspirate as well. So we're also putting more information out there for people. We worked with leaders in the field on the canine side for a joint injection guideline to show exactly how to inject these types of products into the joints. And we've created a poster to go along with this. We're also working on this on the equine side as well. We've just started this project up, but it's going to be very similar. In this guidebook, it's not just going to talk about PRP, because when we know that there's more to the treatment algorithm than PRP, we asked our consultants that are creating these guidebooks to also include HAs and various other things that you guys might be interested in using and how it might fit into your algorithm. And that's all I have today, and I'd be happy to take some questions.
Excellent. Thank you very much.
Thank you for your presentation. So my question is pretty general. So I guess it is pretty safe to say that PRP doesn't really heal tissues. So at most it may have an anti-inflammatory effect. It does have an anti-inflammatory effect. So generally speaking, why would someone take PRP instead of, say, oral anti-inflammatories? I mean, what is, if we were to compare and contrast the two methods, what are the benefits of PRP?
Yeah, so PRP is autologous, as you know. It's also injected directly into the joint, say if you're treating an animal with joint osteoarthritis, so you're getting a really direct effect. These oral anti-inflammatories, I mean, they can have offshoot effect if you take them for too long on, say, various other organ systems. And a big thing that's coming up now on, say, the canine side is a newer monoclonal antibody to, say, block nerve growth factor. We saw that fail pretty miserably on the human side because it really masks the pain, and it doesn't really slow, it's putting a Band-Aid on it. It's not going to slow the progression of osteoarthritis. You could overuse your joint, and then your osteoarthritis is actually progressing faster than it was before.
So does it change like the viscosity of the synovial fluid? Does it have any other mechanical effects? Say, you know, perhaps like HA or some other viscous altering substance?
So PRP is it's not a very viscous solution. It's similar to, say, blood. So it's not going to be super viscous. It could potentially have an effect on the synovium, and change that viscosity of the joint fluid that is then produced afterwards. But it's not primarily meant to be a lubricant, say like HA is, and what that's indicated for.
Thank you. Thank you very much.
Thank you.